That's fine. I did have one question for the panel directed back around current healthcare policy and where healthcare policy is headed in the United States, federal level. Are there any decisions or trends around technology specifically that you see changing as a result of our current focus and direction?
I'll start that. When Carrie gets a microphone, I'll let her, because she actually has policy in her title. The key thing that most of you know about is back when stimulus passed, we had incentives for adoption of electronic health records and incentives to providers and to eligible hospitals. Excuse me. And that has been marching along. We have about $7+ billion in incentives going out for what are called meaningful users. All those familiar with meaningful use, just raise your hands and get a sense of those folks. So for those who are not familiar, it just says that we're not going to give money to doctors and hospitals to buy an electronic health record. We're going to give them money if they're actually using it in a meaningful way. There are several stages. We're getting ready to get stage 2 going related to meaningful use, which involves information exchange. But the goal is to get information in, to move it around, and ultimately to improve outcomes and lower the cost of care. So that's been a big factor. There's been widespread bipartisan support up until about 4 days ago for this program. Most people recognize that IT is an important factor. We have had recent noise related to concerns about how that money is being spent, probably related more to the election than anything else. So that's one big factor. I think the other big factor, of course, with healthcare reform, and whether you agree or disagree with what goes on with healthcare reform, what a lot of people don't appreciate is a lot of the elements within it have been around for some time and also enjoyed a lot of bipartisan support, particularly around the areas of moving toward the payment for outcomes, payment for value, and along with CMS starting pilot projects of accountable care organizations. You see a lot of the private sector having done pay-for-performance and medical home and other sorts of episodes around there. So now that Carrie has a microphone, I'll let her take the policy question.
Thanks. Harry covered it. No, I would say that the federal government is going to set the guidelines for what they want to have happen, but not how. So, for example, my chief executive asked me what meaningful and when I say how, I mean they're not picking technology winners and losers. They're saying here's meaningful use. And my chief executive asked me, well, what are the rules around wireless? And said there aren't any rules around wireless in meaningful use. As a matter of fact, in over 1,000 pages of text, the word wireless appears twice. And that is actually used as an exemption from the rules for the hospital to be able to say, we don't actually have the wireless capability to meet this requirement. And so I think a lot of emphasis right now in the federal space is on interoperability. So the Office of the National Coordinator for Health IT, ONC, is focused on the direct protocol for secure messaging, point-to-point communication. We saw efforts to build a nationwide health information exchange network. We have efforts, state-based efforts. I'd actually love to hear how you guys are approaching exchange. But they're not picking the winners and losers. They're saying we need to have information exchange. This is how it should happen. I think really the experimentation around payment models is where we see the implications for technology. So if you have a set way of doing business and now you have some new constructs by which to do it, then you're okay. We think about facilities are wonderful and they are very appropriate care centers, but they're also very expensive. And if you're going to have almost a fixed amount of money to handle your patient population and you're taking on more risk for that population, you need to know a lot more about what's going on then when they're outside your walls. So you need to think about what are those remote monitoring technologies. We hear a lot about telehealth solutions. How are those things going to enable and change your practice and adoption of technology? And I will just note that legislatively, there are bills coming out around telehealth and licensing. So we agree that there's some serious roadblocks, for example, not letting doctors practice across state lines to treat a patient. Those are some barriers that the federal government can help to eliminate so that, clinicians can get on the business of just delivering care the way they want to.
I can just add to that as well. Living and breathing in health policy on a regular basis. I joked in the beginning of my talk about ICD-10, which is technically part of the HIPAA legislation and will be mandated on October 1st of 2014. And I gave you an ICD-10 code for near drowning, which was one of 252 codes for that. And the point I want to make is that government involvement is definitely necessary in terms of developing these standards, but at some point you have to wonder what's necessary versus what's regulatory. So the 252 codes look at things like, did the patient nearly drown in the bathtub versus on a ferry, which is all great information, but is it really necessary? Do we need clinicians to document that level of detail in order to get the right code? The other thing with the meaningful use incentives, my perspective, again, on the ground, so to speak, with meaningful use, working with my clients daily, is that there's really two camps. There's the camp that have already adopted technology, and this is more or less an exercise to get the money. And then there's the camp of those organizations or those eligible professionals who really need the money to make their margin and are sort of going down this technology path with the intent of receiving the incentive, and perhaps don't necessarily pay attention to some of the informatics type of capabilities that these systems can offer. So they're not really concerned with data integrity. They're not really concerned with how the data gets in. They're really mostly concerned with getting the incentive dollars that the government is putting out there for them. So I see it as a double-edged sword, sort of good and bad.
I think just one other thing to pick up on, one other big policy area, of course, in picking up on what both Mark and Carrie are talking about is we're talking about moving information around, getting rules for moving that information around, but a big concern is obviously privacy and security. And privacy and security in healthcare is different from other areas. How many of you are afraid of someone stealing your identity and draining your bank account? Okay. How many of you are afraid of someone taking your identity and going and get a colonoscopy in your name? Right? It's a different issue, right? What most people are worried about is not sort of wholesale loss of their information. When we survey Americans, what you find is 50% of people have something in their medical record that they don't want to share. It's a rash they got in Vegas. It's some other sort of episode of care that they went for. That they don't want. And if you think in your own record, what is going on with you that you might not want to share with someone across the board? Who's got some information they don't want to share? Thank you for that. And Scott, we're covered under HIPAA here, yes? I'll give you a very quick example. So who knows what Thorazine is? So what's Thorazine?
It's a very old antipsychotic.
It's an antipsychotic. So I'm going to share something about me. That I am allergic to Thorazine. So think about that for a second. Let that marinate. Thank you for your compassion. Who's allergic to something? Someone did. Someone, well, had that happen too. So you've seen your medical record. On top of your chart, it has penicillin, whatever, and it's highlighted in yellow. So on my chart, it said Thorazine. And so, I as a physician, if I saw someone coming in with Thorazine written on their chart, I'd speak very softly. And I wouldn't, come at them with any big needles. But I would sort of fill in the blanks. I wouldn't have a big conversation about it. So we have a lot of clinical people there. Anyone else know what Thorazine is used for besides an antipsychotic treatment? It's for intractable hiccups. And so when I was in college, I had hiccups for 4 days. Couldn't eat, couldn't sleep. It was absolute misery. And they gave me Thorazine. And, I slept for about 2 days. And I woke up and the hiccups were gone. But I had a rash. Now, that's, as short as that story might have been, it's pretty long. And it's not the kind of story that I want to have to tell to every doctor, every pharmacist, every nurse. I don't want to walk into CVS and have the person behind the counter look down, look up and go, hello. Right? And so when we think about, what's important to patients and how we're designing infrastructure and how we're designing information flow, there are some very, very unique barriers to moving that information around and a lot of concerns. So I will then throw it back down the aisle here.
Well, I'm going to come at this from a technology standpoint. In my world of technology, I think about medical equipment and technology. And I don't know if this microphone sounds a little different. So we're working on this project. I do a lot of work in cancer care. And, the idea when you're treating a patient with cancer is you want to move very rapidly from a diagnostic, maybe a mammogram, to an ultrasound. Maybe you're going to go ahead and take a stereotactic biopsy from that patient. Then you would very rapidly verify whether that sample was something that needs to be investigated further, or maybe be seen for consulted for either chemotherapy, radiation, surgery, etc. The pathology behind reading that specimen, just when you look at that one spectrum of how it is we arrange the facility and the equipment for that pathology to be read at the location of where that sample is taken, becomes difficult. And policy and reimbursement and paying for a pathologist to sit out at some site, which might be off campus from the main campus, then you think, oh, well, let's just have a remote microscope, telepathology. Let's put the sample over there, have the doctor be at main campus and look at that. Well, if you really look at how that happens, there's a lot of rapid movement, manipulating the stage up and down, around. That is not something that is easily done remotely. So we look at vendors and we say, go ahead, build some technology, make this possible. The Da Vinci, for God's sakes, you can be across the world and operating on a patient in the OR. Why can't we look at this specimen from, a mile away, a floor away? Well, you look at the reimbursement around reading things like Pap smears and everything that you've got to do with that microscope, and the technology just doesn't pay out. So they build these $100,000 microscopes, but yet you can't put that piece of equipment into an environment where it's not being reimbursed. So we're in this situation where, hospitals are still fighting with the idea of trying to take care closer to the patient, do it in a less costly environment than a big main campus like this, where it's not very patient friendly to drive into the city. But you're not going to take some of your best pathologists either out of their academic setting and make them sit at some outpatient center. So I see policy driving vendors away from some development, and that's just one example.